police. Okay, so welcome everybody. So today's topic hopefully will not be too boring, but it's the nervous system, and I know everybody here knows the nervous system, but I think it's good to review everything because it helps you understand it again. And then just like, does anybody here read books for the second time? I mean, have you guys ever done that? Anybody? I'm the only weirdo. Have you done it? What book? Can you think of one that you've read a second time?
And you're talking about just for
any book
reading?
Yeah, anything.
I mean, like the Harry Potter series, Lord of the Rings.
Lord of the Rings? You read the Lord of the Rings? That's a hard one to read.
Lots of times.
Really?
Many times, yeah.
Yeah, and it's different, right? The second time you read something, totally different, because you're different. Like,
that's exactly what you just said. I actually heard a great story on National Public Radio about that. Was that this guy was talking about every couple of years, there's a book that he loved. It shaped his life, and he reads it every couple of years or such. He reads it, and he says, of course, the words aren't changing, the story isn't changing, but I've changed. So the way that what I get out of the book is reflected differently.
Right. Like I read Lord of the Flies recently, and I read that when I was 16, and my interpretation was completely different. Now I'm 45. I'm like I was a kid, 16, and it's really interesting. Anyway, so that's why I think it's good to go over things, because now you're different. You learned it in medical school or whatever when you went to school, but now you're different. You're older and you have a different understanding, and you've got practice now. So it's interesting to review things. So we'll just get started. What's the nervous system? And it's basically, my opinion, and again, my perspective is one, I'm an orthopedic surgeon, so maybe I'm simple, I don't know. But my opinion is the way that the body communicates with itself. So I gave a couple examples here. Here's, I forget, is he Tom or is he Jerry? Tom?
Jerry's the mouse.
Jerry's the mouse. So here's Jerry. Here's Jerry sleeping. Christina, why don't you tell us what happens here with the nervous system? Why don't you explain it?
It looks like his nervous system is not very active at this point, pretty low key.
Okay.
Here. All of a sudden, the nervous system wakes up.
Why is the nervous system wakes up?
Probably getting a sense that Tom is nearby.
What would it be? What sense would it be? Probably. If you're just barely asleep, what sense is maybe still working?
Maybe a sense of smell.
Okay, it could be smell. Yeah, that's a very good point, because animals have great smell or hearing. So smell would be the olfactory nerve, cranial nerve, and the hearing is another cranial nerve, goes right to your brain. It's pretty powerful. And then what happens? The brain does what with that information?
It's the fight or flight response here.
Yeah, exactly. So and just before maybe the fight or flight response, it goes through its mind, maybe in this frontal cortex, like, what is that sound? Is that a danger sound, or is that a nice sound? Is it my wife? A female rat, a mouse? Oh no, it's a cat, which is danger. And then it brings on the sympathetic system, right? And then the sympathetic system, everything fires and they start running to save its life. So that's like, if you think about it, it's extraordinarily complex behaviors. Hey Doug, good morning. And it happens within like 2 seconds, maybe 1 second, and it's extremely quick, like really quick and very powerful. And another example is a frog, and I like videos, so I'd like to show you guys a video of something. These are all my favorites, and a lot of them are kids stuff, because my kids search stuff. So here you can see is, tell us, Christina, what's going on with this frog? What's the frog thinking?
That he's hungry.
Okay, he's probably thinking he's hungry. What else is going on in his nervous system? What's that behind him?
Flies.
Okay, so it's a fly. Yeah, so he's thinking food, right?
Right.
So he's probably really thinking, he's sort of like a predator. He is a predator, so he's just thinking like, when can I pounce on this fly? Right. So he's also going through his brain. Can you imagine like how close the fly is and what's the probability of catching it? Right. And don't go too early because you'll miss the fly. Now it's getting pretty close, and he strikes, right? And it's gone. You can imagine like all the things that went through the muscles and the eating, and then to do that, and you can see the in slow motion. It's pretty cool, actually, slow motion, of how fast this thing is. That everything is integrated. It goes, cognitive, and then At some point, he makes a decision, and then he acts on the decision quickly, and then all the muscles fire. It runs from his brain into his spinal cord. It's probably a reflex, actually. It's probably a coordinated reflex. It sticks his tongue out and then grabs it. So it's an amazingly quick, powerful process, the nervous system.
I'm surprised he moved his whole body around. I didn't expect him to.
Yeah, it's unbelievable. Isn't it how integrated that process is? It's really powerful if you think about it, and complicated. So how's the whole thing? And if anybody has any comments or questions or whatever, please feel free to interrupt. So how's it all work? Well, just to break it down in anatomy, it starts in the brain, and also you have the spinal cord. So this is what we classify as the central nervous system. And then past that are the spinal nerves, the cranial nerves, and the spinal nerves, and the peripheral nerves. And that's the peripheral nervous system. And it goes throughout our entire body. And it coordinates everything that we do. So what does the nervous system do? I like to think in broad terms, so I understand what I'm talking about. But it senses things. Remember we talked about like where the fly was, what kind of fly is it? It integrates it. So it's like, well, this fly is something that can help the hunger that I'm feeling right now and give me nutrients, and then respond with the massive motor response. So it's a way that you can, I don't think kids do this anymore, do they? They all text each other. But when I was a kid, this is what we used to do. Is a way to communicate with each other. We have like our next door neighbor. We had toucans. So what makes up the nervous system? The basic element is a neuron. And just like anything that's good in life, it's Greek. It comes from the word sinew, right, Spiro? Anything that's good is Greek. Feta cheese, yeah, dancing. It comes from sinew, tendon, cord, or bowstring, because it looks like a cord, and it's the neuron is the basic cell, and the neuron is made up of several parts of the cell body, which has these little dendrites, which are extensions, which help it communicate with other neurons and maybe the environment. And then it sends a signal down an axon, which is sort of like the highway of the nerve. It runs the message. And this axon, who can guess what the longest axon in our body is? Doug, you're hold on a second. Sorry, guys. Hold on. This is the next. So what do you think is like the longest axon?
It's probably the one that's farthest away from the spinal cord of the brain, so probably the big toe.
Yeah, right, exactly. So your toe, the L5 nerve root, and it starts in your conus. So that's about a meter almost. That's a really long nerve. And then it ends in the axons, which communicates with other cells. And then the axon is myelinated from the glial cells. So glial cells make fat, and this conducts the electricity. So the nerves, the axons of the nerves has an outer layer that insulates the nerve so that it can work. It's kind of like a wire. So our body is wired. And why does it have to be insulated? Because it's electrical. The way that it works is sodium and potassium ions, or these gates in our nerves, open and close, and it gives a polarized, conducted neurological impulse running down your axon to make these things work. So it's got to be insulated so that you don't lose the electrical current somewhere else. So it just runs down the nerve. And here's what a nerve looks like. Doug, how would you explain what a nerve looks like to Adam? So, like, what's he looking at right here? I'm sorry to interrupt you, but you're a surgeon, so I thought you could tell us. You do carpal tunnels?
Yeah, a nerve.
What's it look like? Here's a picture. So kind of explain what are we looking at here? It's probably what?
Sheath.
There's a sheath, and what surgery is this probably? There's an M. Kind of helps you.
Could be a median nerve.
Yeah, so it could be the median nerve in a carpal tunnel surgery, and the nerve itself, like how big would you say it is? Like a piece of linguine, or?
Median nerve is sort of a piece of big linguine.
Like a big linguine, sort of.
Is that Greek?
No.
Ethnic food or?
No, Italian.
You know, the median nerve is kind of about the size of my pen. And it tends to be shiny. It doesn't have tension on it. It's lubricated. It has some paratenon and epineuron, so basically structures that protect it, surround it. It's tubular. It's sort of like a moist insulated electrical wire.
Mm-hmm.
It's not terribly mobile. It tends to be fixed in the sheath.
Mm-hmm. And nerves, they can get caught up in places. So like the carpal tunnel is one.
Caught or compressed, yeah.
Yeah, so the carpal tunnel is one space where we know it commonly gets compressed, but in the forearm it rarely gets compressed. Sometimes. Where's another place, would you say?
Well, the epitrochlear area.
Cubital tunnel. Yeah, the cubital tunnel for the ulnar nerve. Yeah,
ulnar nerve and the wrist also is Keown's canal.
So we know, as surgeons, we know all these places where people can have problems because that's what we do. We have to understand what these. So that's what the nerve looks like. And let's say you cut a nerve, and the nerve does look a little bit like a tendon. That's why it's called a tendon in Greek. So if you cut a nerve open, here's an axon, and then you get a bunch of axons to make this fibril, which you can see in the nerve. If you pull apart a nerve with your fingers, which you shouldn't do, but sometimes it happens, you can see a tiny little fibril, and that's made up of many axons, and then all the fibrils come together to make up a nerve, and the nerve's covered with a perineurium and an epineurium, and the perineurium is basically the extension of the dura from the central nervous system. We'll go over that in a second. So just to review, you have the cell body, and then a current runs down the axon, and then it stops at the synapse, and the synapse, to communicate with the next nerve or muscle, whatever it does, it sets off chemicals, and these chemicals are called neurotransmitters, and the chemicals get accepted by the other cell, and then they create a new stimulus running down the nerve. So any questions about that or comments? Okay, so we'll keep talking about anatomy and structures. In the brain, in the central nervous system, in the brain, the cell bodies are on the outside, the gray matter, and on the insides, the white matter, which are, again, we said the axons. And then the brain ends at the foramen magnum, the hole in your skull, and then runs down your spinal canal, your spinal cord. And then that relationship is inverted. In the inside are the cells, the gray matter, and on the outside are the axons, or the white matter. That makes sense? And then at every level in the spine, there is a hole, the foramen, and the little nerves exit the spinal cord and run out the hole. And there's dorsal and ventral nerves. Dorsal is for sensation, and ventral is for motor. And they exit, and they in the foramen there's a dorsal root ganglion. And the dorsal root ganglion are the cell bodies of the sensory nerves. So we'll get into that in a second. So the nervous system also has an autonomic and autonomic system of sympathetic and parasympathetic. So these are all man-made subjects. So we kind of created these systems so we can understand them, but they're all connected. So the sympathetic system, like Christina said, is fight or flight. So who can name some? Megan, name some sympathetic systems. You can cheat by just reading it that you know of.
Sure, blood vessels and sweat production.
Mm-hmm. Okay. Sweating and blood vessels and breathing fast. Your pupils dilate. So here's let me show you I like movies. So hold on. So here's a sympathetic system working.
What happens when a beer tastes both refreshing and flavorful?
So pupils dilate, skin gets clammy, hairs on end. So you can see that's like somebody getting excited. So I love that commercial because it's a sympathetic system. I also like Guinness beer. And then the other one is parasympathetic, where you're relaxing, and the gut is becoming stimulated for absorption. It's a totally different. The heart slows down, your airways become constricted. It's a totally different like response of the body. So what does anybody know what happens when you put your hand on an oven? Like, why is it that your hand is so fast to come off? It's like super fast. Does anybody think, like, are you think
Spinal level?
Yeah, so it's a reflex. So it's a system where this is a reflex too. When you tap a knee, it stretches the tendon, and that stretch it goes through a receptor in your muscle. It's like something's wrong, and that runs down the axon into the cell, into the body. Remember we said the dorsal root ganglion where the sensation is? That's the cell body. And then that sends another interneuron to the spinal cord. It connects here in the dorsal horn. That connects to another a cell body. And then from here, it's one axon that runs all the way to your leg and then fires your muscle. So why would you have a stress response? Like, Rob, when you were in third grade, did anybody, when you're standing, everybody go behind you and hit your knee from behind to make your knee buckle?
No, they knew better.
Huh? Never? No one ever did that to you?
Killed people who are.
Yeah, I mean, like, not a hard one, just barely hit the back of your knee so your knee buckles. Anybody ever do that?
Yeah, sure.
And so why don't you fall down? Why doesn't it make you fall down?
Because the body's reflexive system kicks in.
Yeah.
Proprioceptors.
Yeah, exactly. Your proprioception is really, really quick, but not quick enough where you do buckle a little bit, but you don't fall down. That's what I think. Does anybody have any other opinions? That's why I think we have these reflexes, so that we're always standing or things are always working. What do you think, Doug? You think so or no?
I don't know. Do weebles have that kind of reflex?
Okay, you're in a weird mood today.
Protective reflexes, like, for everything, when there's a probably primitive, if there's a predatory response, you have a, fight or flight. I think that's probably where it comes from.
Okay, so let's describe where the nervous system runs. It runs down a canal, and this is the spine. So in my mind, I explain the spine as a column of cubes, one stacked on top of the other. So you can see it kind of does look like a column of cubes, one stacked on top of the other. And there's a hole where the spinal cord and nerves run, which is called the spinal canal. And it's within the spinal canal where our spinal cord is housed. So this is a vertebral body. This is one bone in the spine, and then you stack a whole bunch of them. That makes the entire spine in the spinal canal. Now, the spinal cord, when we're in the third month in pregnancy, ends all the way down at the sacrum. And then as we grow, the spine bones grow, but the spinal cord itself doesn't grow that much anymore, and it starts to go upwards in the spinal canal. So you guys understand what I mean? So our spinal cord, most spinal cords end at L. Adam, where do you think most spinal cords end?
L1.
L1.
But anywhere from T12 to L2, the bottom or the top of E12 to the bottom of T12.
So the variance, because you look at these every day,
Right.
T12 to L2. What's the highest you've seen? T12.
Yeah.
And what's the lowest?
Probably really just below L2, not
Just below
L2.
L2?
I mean, other than a pathologic situation of a tethered cord or something like that.
Tethered cord with a phylum terminalis keeping
Right.
it from going going higher. Yeah, so L2, maybe I've seen in pediatrics, I've seen like L3, but I think it was a tethered cord. So that tells you the cell bodies are usually higher than the numbered bone level. So there's a nerve that runs down because the spinal cord has gone up. Does that make sense? So where the nerve exits is usually a lot lower than where it starts in the spinal column, because it has to run down because, again, the spinal cord has gone up, sort of, because the spine really has gotten bigger. So it has to travel down. And in our spine, we have 8 cervical nerves, 12 thoracic, 5 lumbar, and 5 sacral. So the cervical one's weird because we have one more nerve than we have a bone, and that's because there's a C1 nerve that's above the pedicle, and there's a C8 nerve below C7 bone, and that's just the way we describe it. And the bottom of the spinal canal is called the cauda equina, and we'll get into that in a second. So this is a skeleton. You see the whole spine, and then at each level where the two bones connect, there's a foramen, and that's the Latin word of hole where the nerve runs out. And you can see the pen. That's exactly where the nerve runs, and the nerve can be compressed there, because there's many things there. There's the facet joint, which can get hypertrophic and has a capsular tissue and compress the nerve from that direction. And then from the other direction, there's a disc, which can herniate and hit to the nerve. And also, at the level of the disc, you can get an osteophyte off the end plate. That can compress into the nerve. So it's a combination of things in the hole in the foramen which can compress it. And who can remembers what real sensitive nerve tissue that's in the foramen that gets really irritated in the foramen if it gets compressed? It's like sort of like the brain of the sensory nerve. Remember, the dorsal root ganglion. So the dorsal root ganglion, which is sort of the brain center of the sensory nerves, because the cell bodies of the sensory nerves are in the dorsal root ganglion, which is in the foramen. So that's why foraminal pain can be horribly painful. And a lot of times when these patients come to the primary care physician said, this patient's crazy. Sciatica is not that bad. And I don't see why this patient has so much pain. Well, it's because it's hitting the dorsal root ganglion. So there's a reason why it's so painful. So also within the spinal canal, Adam, tell everybody what all this white stuff is here.
Well, the white stuff, this is what we call a T2 weighted image on the MRI. And on T2, fat and water are bright. So you can see posterior to the spinous process right down by the P all the way back.
I'm sorry, posterior, okay, yeah.
Right there, that's some fat posterior to the spinous process, and that's bright, and then in the spinal canal, the white is the cerebrospinal fluid. Right in the very center of the center of the tissue, back a little bit more, back, up a little there. That's the conus medullaris. So that is where the spinal cord has that pencil taper, and then all those little dots around it are all the nerves, and that we call the horse's tail, the cauda equina, and those are like the hairs of the horse's tail coming off the spinal cord. So each one of those dots is either a ventral or a dorsal root nerve coming off the spinal cord.
So this is a nerve, this is a nerve, this is a nerve, this is a nerve. So where do you think this? If you had to guess, do you think it's like right here?
Yeah, or a little bit higher. Yeah. So
you think
5,
right about
4,
here?
3, 2, 1. Yeah, T12L1, a little higher. Yeah.
Okay, and this person's spinal cord ends where 5, 4, 3, 2, 1 at the L1, L2 disc space. Is that kind of normal?
4, 3. I'd say 5, 4, 3. Yes, L1, L2. Yeah.
Okay. Yeah. Okay. Great. And the other thing is, you remember, like, this is probably where S1, like S5 comes off, S4 comes here, 3, 2, S1 here, and then L5, L4, L3, L2, L1, and they all travel down the spinal canal. So it's very interesting. I saw a great example of conus medullaris when I was at University of Maryland, and we decompressed a 2-year-old child whose conus was compressed by this weird lesion, and the whole the thecal sac was flattened from this process. It's weird. There's no way I can explain it to you. She had like a congenital kyphosis, and we did a laminectomy. We could see the entire conus and where exactly the nerves are going into. It was amazing. I wish I had taken a picture of it, but so again, this is a model of this is a skull, back of the head, and the cervical spine, and this is the same model, and that's and the woman model is my secretary Crystal, and she held it for me, and she took this same model and put it on end, and she's looking through the spinal canal, so you can see what the spinal canal looks like. It's a tube, and it runs down the center of this of the spine where the spinal cord is housed. And here's what Adam was describing. Here's the horse tail, and here's the cauda equina, which is the horse tail, and it kind of looks a little bit like a horse tail, where all the nerves are coming off. And you can see, like, these are the sacral nerves probably, and this is S5, S4, S3, S2, S1, L5, L4, L3, L2 maybe. So you can see how the nerves are in the lumbar spine. And this is an example maybe in the thoracic area. You can see, again, the spinal cord and the gray matter where the cell bodies are, and the white matter where the axons are, and where a dorsal root, which is sensory, comes off, ventral root, which is motor, and then they connect here, and the nerves are covered by the dura and the arachnoid membrane, and then those comes together right here in the foramen, and it becomes perineurium. So you don't have any CSF from here down. It's just nerve, because those membranes become adhesive to the neurological tissue. And this is the dura is the covering of the nerves, and there's also an arachnoid membrane, and then the CSF is deep to the arachnoid membrane, and you can get bleeds here. So you can get so Adam, how do you categorize the areas in the spine that can have like problems? If you have a bleed, where could it be? Could it be?
You could have epidural.
So epidural would be right here on the outside.
And then you'd have subdural.
So between the arachnoid membrane and the dura, you could have that, and that's usually in the brain. You see that,
Yeah,
right?
and then within the parenchyma,
subarachnoid?
Subarachnoid, yeah.
So between the,
Where the CSF is.
Yeah, where the CSF subarachnoid. So between the pia and the arachnoid membrane, you can have a subarachnoid.
And then in the parenchyma itself.
And then in the parenchyma itself, like an intraparenchymal. That's mostly for our brain, right?
Yeah.
Okay, so yes.
Question about doing an LP, and the space we usually go in, is there any risk of hitting any of those notes coming up?
Well, let's look.
Absolutely.
So where do you put? So here's the top of the pelvis is where L4, L5, right? So you're putting it right here. So which nerves? What could you do? Just let's be imaginative, like for kids, and we're not experienced doctors, but we're kids. What could you hit there? Maybe. What could you spear?
Where you could hit the cones, I suppose.
Yeah, you could hit
streaming down posture.
You could hit the S1 nerve root.
Yeah.
So why doesn't that happen more often? I don't know the real answer to this. I'm just
Because they
asking.
move out of the way.
Yeah, because the needle's beveled, so they kind of just slide past the needle. But it's possible. I mean, if you're a surgeon,
I've hit them.
yeah, you hit them. Yeah, I'm saying if you're experienced, you've done every bad thing that there is to do. You can get it. You can hit the rootlet, and
Patient usually tells you right away.
yeah, something's not right.
Or, ow.
Yeah.
I felt that in my foot.
Yeah, so it's possible, but it usually doesn't happen. I think because of that. And also in the spinal fluid, like we always think the body is a statue, but the body is actually moving around constantly. Like the heart's beating, the CSF is pulsating, the nerves are kind of floating in the CSF. As the CSF is pulsating, the nerves are floating around. So it's kind of like it's a moving target too. So it's like it's bathed in fluid. So that's why it never happens, but it can. So I've thought that same question actually.
And then also if the patient's post-operative and there could be scarring, and the nerve could be adhered and it won't move.
Yeah.
So then when you hit it, you can really hit it, and it's like somebody's holding it. You're trying to hit a boxer like this, and he's moving his head, and then you take somebody who clamps their head still, and you hit it. You really hit it, and you can sever it.
And that exactly what you said happens with recurrent disc herniations too. So you do a discectomy, like a virgin disc herniation. The nerve can move somewhat because there is room, and the nerve can move within the spinal canal.
Mm-hmm.
But if it's a recurrent disc herniation, the nerve is stuck in scar, and then you have the disc herniation hitting it, and the nerve can't move. It's kind of held there.
Yeah.
And so those patients a lot of times have severe pain because of that. And it's because it's tethered.
Yeah.
So that's another thing in surgery that we have to think of is like in a recurrent disc herniation, sometimes it can be extremely painful, like worse than you would expect because it's tethered. Okay, so the spinal fluid, so we've been talking about spinal fluid, so let's talk about spinal fluid. Where does it come from? It comes from the ventricles in a choroid plexus. The cells secrete the spinal fluid. And how much spinal fluid does it secrete? Somewhere between 400 and 500 cc's a day. And inside of our body, we have about like maybe 125 cc's. So it's constantly being made and absorbed, made and absorbed, made and absorbs. And what does it do? It cushions the brain. So the brain's sort of floating. So here's a brain. You see how this brain is floating in like water, sort of, and it's being cushioned. This is my favorite movie, actually, Young Frankenstein. So it's a cushion. So if I Doug says something smart to me and I hit him in the head, which sometimes I want to do, but I haven't done it, the brain doesn't absorb the shock because it kind of is like it's floating in the fluid, so it's absorbed, it's floating and it protects it. Also, it makes the brain, it's buoyant, so the brain is sort of like has no weight, it's floating in water, and that allows blood to flow better. And the other thing the CSF does is CSF is living. So why do you do an LP? What's the whole point of the LP? You started it.
Lots of reasons. Infection usually.
Yeah, and so how do you know there's an infection through the fluid?
We look for cells. You do a gram stain look for organisms.
Yeah.
Look at the protein glucose levels.
Yeah, so the immune system's running through the CSF, and then and there's also proteins, and there's all sorts of things. There's glucose and there's sugar, and that's the nutrients. So it has immune function and its nutrients function. So it's sort of like a way for the nervous system to function.
Talking about the brain floating in the fluid it's what a hangover is, or a big part of a hangover is the amount of you're dehydrated from your night of drinking because the alcohol's diuretic, and the amount of fluid that your body can make to support the brain is less. So essentially that brain that is floating within the skull actually has sunk down and is more touching the bottom of the skull, and that's some of what that aching irritation of a hangover is. And so that's why rehydrating is one of the best ways to help that headache.
That's because Adam he has really big benders, most you get that dehydrated.
They have like vans and things now in Vegas where you can go and they'll put you on IVs and everything else. It's a new business where
Is
they're
it?
rehydrating people. Yeah, exactly.
Sure. Okay, so the other thing is, this is just explains how the spinal cord works. Is this is the motor side, the ventral side. This is the cell body in the motor. It runs all the way down to the toe, like Doug said. And then there's neurons within the gray matter. And here's the sensory cell body is here in the dorsal root ganglion, DRG, and that sends a signal into the spinal cord. So this is one of my favorite cartoons in medical school, is the homunculus, which is in the brain, which shows us the sensory and the motor functions in the brain and where it actually sits inside of the brain, and it shows the relative size of the number of cells that are responsible for both sensory and motor. And you can see, like on both sides, both motor and sensory, we have a tremendous number of cells for the face. And I guess why is that? I guess this input like things in our environment, but also we communicate through our face. So it's like the face is like really like powerful part of your body. And then this is just it shows what Adam said, the different spaces. Like here's the dura, so you can have and this is where between the dura and the arachnoid, and between the arachnoid and the pia, just subarachnoid, and then the parenchyma. So this is just one more review of how the nervous system is organized. The central nervous system goes to the peripheral nervous system, and you can break the peripheral nervous system into sensory, which is the afferent nerves, and touch, pain, pressure, vibration, temperature, proprioception, for balance. Remember we talked about with Rob. And then there's also visceral sensory, so you feel like stretching, pain, temperature, chemical changes in your abdomen. And then somatic, or bones and joints, you have both motor and visceral. And then within the visceral motor, you have both sympathetic and parasympathetic. So there's different types of sensation. There's light touch, there's cold, there's heat, there's stretching sensation, and there's sharp or pinprick. And they all come from different sensory, like little organs or receptors. And I won't go over this, but Ruffini's corpuscles for pressure. I've forgotten all these things from medical school. The hair follicle has a receptor. For deep pressure, there's a Pacinian corpuscle. Free nerve endings are for pain and temperature. So we also have, again, the proprioceptive training. Like, do you guys as therapists do proprioceptive training? What do you guys do?
A typical thing that people think about all the time is a BAPS board, like that blue thing that you do with ankles.
Like a skateboard, sort of. It's like a skateboard on
It has
a
like
ball.
a ball on the bottom,
Yeah.
and so you move it in all the directions.
There's some stuff out there for hands. There's something called the We take away other organs, we take away the vision, we take away the surface, change the surface.
So you're teaching the patients to understand their position in space, right, and their body. So I don't know, like, is anybody here like a basketball player? Like when my brother and I played basketball, we used to just play and we felt normal. But then if we hadn't played for like years, which is now the case, I played like once every 3 years. We're running down the court. It's like I feel like I'm in an alien's body. Like I have no idea where my body is. You know, how to catch a ball, how to run, how to stop. So I think it's because my brain and my proprioceptive training is gone. And that's why some athletes have unbelievable proprioception. They know exactly where their body is at all times. You know, so that's why I think that's what I think proprioception is, what it's all about. So there's one more thing. We're getting done. As I know it's boring. The axons end on the muscles, and then the muscles fire, and the axons end in the muscle tissue, and then when it gets into the muscle tendril unit, the whole muscle fires. So that's how it works. In muscles, the nerves can end in muscles, which totally fire, and also the same nerves end in the muscles within the gut. And this is it's a different action, and I won't get into it. So cranial nerves. I thought maybe we can go over the cranial nerves. There's two sets of them, right? You have a right side and a left side for every cranial nerve, and let's go over who wants. So olfactory nerve, smell, right? Optic nerve, vision, so you can see, it goes straight into your brain. Now these are I always forget, these are ocular motor, which controls a muscle within your eye, and there's ways to test this, and I'm not a neurologist, so I've forgotten it. And trochlear is another muscle that keeps the eye from going upwards. Trigeminal nerve is kind of a complicated one. It gives facial sensation, so it's a really big nerve because our face has a ton of sensation. And there's 3 branches, 1, 2, and 3. You can see how there's one on the top, there's a maxillary one, and there's a mandibular one. It's also the corneal reflex, so you can test it by putting a little Q-tip on your eye, and you should blink. And it's also motor for your mouth, so clenching your teeth for eating, moving your jaw back and forth. The 6th one is the abducens. Again, it's an eye. What's the facial nerve do? Smile, yeah, smile. And it also the front of the tongue, anterior 2/3 of the tongue, and tearing. Your tears when you cry. So when like Doug cries when the Orioles lose, it's from the facial nerve. The 8th nerve is vestibulocochlear. So the 8th nerve is what? Anybody? Hearing, and also balance. So Christina, can you do this? Is your balance this good?
No, my daughter can.
Your daughter can? So glossopharyngeal is taste the back of the 3rd tongue and swallowing, and also the gag reflex. The 9th, the 10th is the vagus nerve, which controls the heart, the heart rate, and also some muscles of the tongue and throat. The accessory nerve, I remember it as a shrugging. So when you're like this girl's shrugging, your shoulders go up. That's the accessory nerve. The 11th.